radiofrequency for catheter ablation. So when you're talking about catheter ablation, we talked about how we're trying to get rid of these abnormal cells from the inside, and we use an ablation catheter to do it. And the ablation catheter is a catheter that goes up the same way as the diagnostic catheters under X-ray into the heart, and you try to position the tip of it where there's a cluster of AFib cells, and using a energy source, because depending on what type of generator that the catheter is hooked up to, the tip could either become very hot, very cold, or with the newer energy source that just came out in 2024, the pulse field ablation is using electrical pulses to kill off cells without destroying the architecture of the cells or the cell membranes and everything, so less collateral damage. But irregardless of what energy source you use, you are trying to destroy the cells. So the question becomes, well, which energy source to use, and is one better than the other? So radiofrequency is heating. That's making a little burn or cauterization to destroy the cells. It's the oldest energy source. It's been around since the late 1980s. And yes, it has become a lot more refined since that time, but it's the energy source that's been around the longest to do ablations, especially for atrial fibrillation. It potentially can cause the most collateral damage, because when you're burning cells, you could inadvertently damage or destroy surrounding cells that you don't want to damage. But on the other hand, it also offers the most flexibility and versatility, because you can reach virtually any area of the heart to cauterize it, whereas you can't necessarily do the same if you're freezing or currently with the newer pulse field ablation technology, because of the shapes of the catheters and how they were designed. So it's the most versatile, but it also potentially has the most collateral damage. Now, way back when atrial fibrillation ablation was in its infancy, that was actually the late 1990s, early 2000s. I came out of training from Stanford in the early 2000s. Atrial fibrillation ablation was very primitive. Doing basically part of that first wall, like a small 5 to 10% forest fire, 10 or 15%, somewhere in that range, doing not even that whole first wall, the back wall, the posterior wall where AFib always starts, just doing parts of it in the corners where those veins, the pulmonary veins, insert that return blood flow back to that chamber. In those early stages of AFib, that's kind of where the AFib is, and it's not really spread to any of the other walls. So in those, that would be considered to be an early, easy paroxysmal AFib case these days. Well, back then, that was extraordinarily difficult. I mean, I remember we would take 8-9 hours to just do part of that one wall. We couldn't do anything more. Our catheters were very primitive. The cauterization was very ineffective, made incomplete burns. So the likelihood of success was very low. Just doing that would take 8-9 hours, 4 hours to do part of that wall, take a break, leave the patient under general anesthesia, run off, quickly get something to eat, come back, spend another 4 hours, do the other part. And not only was the success rate probably 50-60% likelihood of success, but the rates of complication were extraordinarily high. I mean, 7 to 10% chance that we could damage the vessels, we can make a hole in the wall of the heart, we can cause clotting and charring and strokes. So it was very primitive, and it took a really long time. Fast forward, over 20 years later, whether you do it with the cauterization catheter or freezing is even easier to do that back wall. Almost anybody, even if they're fresh out of training, could freeze that back wall and get most of it with a very high success rate, 80-90% success rate in these early cases, and only spend an hour and a half. So things have come a long way. But what it's also enabled us to do is, those of us who've done this for a long time, it's enabled us to use the advances in the cauterization catheter or radiofrequency, that's the energy source, to be able to do much more complex ablations. Not everybody does complex ablations, but it's enabled that ability for some of us to do much more complex ablations, where I can do stuff on all 6 walls in a very advanced case in under 4 hours, which I couldn't have done 15-20 years ago. So it's a good energy source, but there is potential for collateral damage. But the thing that people need to understand with the ablation is, irregardless of energy source, you have to look at, always return to if you're thinking about doing an ablation, what is your AFib stage? And more specifically, how many walls do we think you have AFib sources or triggers on? If you're in it 70-80% of the time, and we think that most of your walls are covered with these AFib triggers, then somebody going in and doing a very simple ablation on that first wall, even if it's with an energy source that lets them do it in an hour and a half and get a good result, well, that's like the analogy would be, it'd be like taking a 70-80% forest fire and doing 15% of it. Well, that's not going to be enough. I mean, it might make it less, but it's not going to make it mostly gone or even all the way gone. And it's certainly not an all or nothing thing. And so you really have to see not so much always what energy source is being used or how the ablation is being done. It's what is being done. Same thing with like a forest fire. If you say I have an 80-90% forest fire and one person uses a plane to dump chemicals to put out the fire, great. Another person's using a little fire extinguisher to put out the fire little by little. Okay, well, it's going to save them a lot more time to use the plane to dump out the chemicals. But what if the plane can only reach 10% of the forest fire, 10 or 20%? Then that means the other 60 to 70% of the forest fire isn't going to be touched and they're still not going to get the result. Then you're still better off with the person doing the little fire extinguisher. It might take them a lot longer, it might be a lot more difficult, but if they can actually reach all of the fire and they have the skills to do it, you still may be in a better position. You need to think about it that way. It's not necessarily, oh, one energy source is dramatically better. It's what is actually being done. Because when technology advances and we go to more advanced energy sources, they always do one of two things. They either allow us to do something better or more than what we were able to do, or they allow people who weren't very good at doing it the standard way to do it more easily so that it raises the baseline standard for everybody. So in every field, you always have those who are doing something advanced, cutting edge, or better, and then you got kind of the average people. It is just the way it is in every field. The average people may struggle to do the more advanced or complex procedures and may not be able to do it. So if you come out with a new technology, it may allow everybody to do that more advanced standard. And then the ones who are really pushing it can do possibly even more. They'll figure out ways to do even more. Or it allows, even the people who are doing more advanced things to do something that they were never able to do before. So it's not necessarily as simple as something's better or not. So when it comes to radio frequency, there have been a lot of advances in the last 15, 20 years to make it safer and make it more versatile. And one of the problems we had before was there was high risk with it, but then also we weren't making very deep burns. And so a lot of these abnormal cells were so deep in the walls, we just couldn't get at them. And so our success rates were just limited by a certain level. But now, because we have transistors in the tip of the catheter that allow us to sense force, how much force we're putting on the heart, then we can more safely go to higher power settings to make deeper burns and be less likely to, cause a hole in the heart with dangerous bleeding and some of those complications, but increase our success rate. But that involves greater skill level and experience to do that. If somebody's going to just use the standard settings, they may still not be able to get deeper burns and still be limited in terms of what their success rate is. So bottom line is and also it's actually using the cauterization catheter, the RF catheter, is currently the most difficult way skill-wise to do it, because you have this tip of the catheter that's 4 to 5 millimeters. It's not very big, and you get to a spot where there's a cluster of atrial fibrillation cells, and you have to have the skill to stay on that spot for 30 seconds to a minute, because the catheter keeps wanting to slip off and slide, and you can't stay in one spot. It takes a lot of skill with the knobs and the catheter. A lot of people don't have that skill. So when things were advancing, and it took us 9 hours to do just part of that first wall, then after a number of years, many of us got to the point where we could do that in an hour or 45 minutes. But there were still people who were taking 2, 3, 4 hours to just do that back wall. If you're because it's dot by dot, you have to stay on that spot for 30 seconds to a minute, and you will end up destroying about 3 to 4 millimeters worth of cells. And then you move to the next spot and you have to stay there for another 30 seconds and then kill another 3 or 4 millimeters. It's really dot by dot. It's the analogy of like putting out a forest fire with a little fire extinguisher, and you're doing it spot by spot. So it gives you a lot of versatility, but it takes a lot of skill and can take more time if you're not as good with your hands or you're not as skilled. So if you're taking 2-3 hours to do one wall the bulk of stuff on one wall or part of the wall, then there's probably no way you're going to be able to do a more advanced ablation on other walls. You wouldn't even try to develop that skill because it took you forever just to do in one wall. And then another modality like the freezing balloons come out and that lets you do that one wall in an hour and a half. Well, then a lot of people are going to do that because it's a guaranteed way to get a good result and be done quickly. But those balloons don't reach all the other walls, and so they're more limited. So like the analogy of the forest fire in the plane. So some people of us are able to do very complex ablations using radiofrequency and don't take very long to do one wall or two walls, so we can do a lot more in one sitting. Some people less skilled and they may be able to do multiple walls, bigger forest fires, more complex cases, but they may have to break it up into 2 or 3 procedures. And then there are those who just don't have the skill and they just do one wall and oftentimes use an easier modality to do that. But if you have a much more complex ablation at a different stage, they can do multiple procedures on you. And if they keep doing the same one wall over and over and over again, the same 20% of your forest fire, if you have a 70% forest fire, they're not going to get it. But they'll bill you 3 or 4 times. So think about it that way. Yes, there are advantages and disadvantages to different energy sources, but think also, it's not just the energy source. It's not like we're all doing the same thing. It's what is being done, how big is my forest fire, what is being done, not just how it's being done, not just what's the energy source. You can do whatever energy source you want, but if you're not able to do a complex ablation on multiple walls, you're not going to get the result for these persistent, long-standing, persistent cases.